Hello. Welcome to the audience and to the audience online too. Welcome also to panelists. We will have with us Pat Gorman, who is one of the most experienced ILD nurse, because she's ILD nurse in Northern Ireland from 2013. We have with us Elisabetta Balestro, who is a professor and director of the School in Respiratory Diseases of Padova in Italy, and also leads the ILD clinic and responsible for lung transplantation patient evaluation. And Professor Vincent Cotin from Lyon in France, who is a professor of respiratory medicine, also head of the National Reference Center for Rare Pulmonary Diseases, and a lot of other things. Thank you to be with me. So this session is designed as a conversation, not as a usual session with a lot of slides and presentation. We want to explore together why early diagnosis is still come often too late for many patients, what prevention really means in pulmonary fibrosis, and also what actions are needed next to improve the situation. So we will start with a short poll. If you go to Swapcard, I think it is live conversation, something like that. It's only for patients. So I will ask a question to patients. How long did it take for you from first symptoms to diagnosis? Let's be clear, I am really talking about first symptom, not first referral to a clinician or a physician. So from first symptoms to diagnosis. Thank you. We will have the result at the end. So during this time, let me talk about Claude's story. Claude is not a fiction character. Claude was living near Bordeaux in France. He has always been very sportive, playing in his city football team till 50 years. And then running a lot of marathons, trails, and so on. His story with pulmonary fibrosis begins in 2015. He was 69 years old, and he developed shortness of breath when running. And nothing alarming at this stage. These symptoms were attributed to loss of fitness and age probably. But the symptoms persist, and from 2015 to 2017, he tries to adapt his lifestyle, continuing physical activity, but remaining breathlessness, and but no further investigation at this stage was performed. In 2017, finally, he was seeking medical care. A chest X-ray was done, and he was referred to a pulmonologist for the first time. An hypothesis was made that it is due probably to environmental exposure to birds, because he was feeding birds in his garden. But this was never confirmed and never evaluated after. So over the next 2 years, he was repeatedly treated for bronchitis with aerosol and corticosteroids. And his condition slowly worsens during this time. So in early 2020, the situation was alerting him and his family. He has lost a lot of significant weight. He presents digital clubbing, And at this point, the general practitioner becomes concerned and initiates urgent referrals to an expert center. In May 2020, so nearly 5 years after the first symptoms, the diagnosis was finally made in the expert center, pulmonary fibrosis. Treatment is started immediately, oxygen therapy on exertion too, and antifibrotic medication. But the disease was already advanced, so by September 2020, he needs oxygen 24 hours a day. He loses his independence, and despite follow-up, his condition continues to decline, and he finally died at home in February 2021. So what does this case teach us? The symptoms were there from the beginning. So, Elisabetta, from your view, where do the diagnosis delays usually begin?
Thank you, Jean-Michel. In my perspective, I think that there is not a matter of lack of knowledge nowadays or lack of tool, but it's a matter of how to use, who use, and when use the right tool in the right setting. Probably the great delay or the delay in the diagnosis of pulmonary fibrosis start very early in the natural history of patients and probably before the patients entering the health system. I mean, symptoms are vague, symptoms are insidious, symptoms are specific, and probably we have to teach a general practitioner that symptoms comes very early and are similar to other diseases. So probably the strategy could be to start very early educational program with general practitioner, but also among population, educating that symptoms are heterogeneous and the perception of symptoms could be different among all the population affected by pulmonary fibrosis. So sometimes we have patients that seek the clinical attention of the hospital, but some other time the delay is also related to the seeking medical attention very late because of misinterpretation of the symptoms, probably because of smoking history, because of age, because of the diagnosis. So the great deal is regarding symptoms of patients, and so educate population, citizens, regarding pulmonary fibrosis that exists and is not something that is so rare as we are usually think about. And again, educate the general practitioner to take care of the patients and try to figure out when there is unexplained symptoms, respiratory symptoms, with age, in combination with smoking history. So try to figure out a sort of chart of risk factors that could guide general practitioner and drive the speed up all the other pathway with the investigation. So this is the critical point, and we have to think about strategy that took place very early in the natural history of the disease to detect, of course, pulmonary fibrosis at the early stage.
Okay. And Pat, from your experience, what do patients often describe as in this period before diagnosis?
Patients often, the symptoms are very subtle. They dismiss them. They usually put it down to aging. Maybe they're unfit. If there's a smoking history, they're blaming the cigarettes. And in the female population, sometimes they're also blaming things like the menopause. There's a gradual decline in function. I can't keep up anymore. They start to adopt their lifestyle. They Instead of using the stairs, they're taking the lift. So the progression can go often unrecognised for quite some time, which again delays in the diagnosis.
Okay, so symptoms are not always very typical and specific to this disease. Vincent, from your opinion too, what are the potential barriers to a timely and accurate diagnosis?
I think the problem is that the barriers are numerous. So there are several barriers, several steps, and that's probably the main reason why it's difficult to actually overcome these problems, is because we have many steps that we need to improve. And we've heard the first part, Pat described that the patients have non-specific symptoms. So the first, on the left of the figure, you have some of the factors or examples which are related to the patient themselves, where they tend to think, well, I'm short of breath, but maybe it's because of the menopause, because of age, because of I put some weight on, or I just stopped doing some exercise, or whatever the reason, or I've smoked. And no, it's not normal to be short of breath, even at the age of 60 or 65. Even if you have smoked in the past, if you are short of breath, you should see a doctor. And I think we need to advocate for that, because it's something that is underestimated in the general population. But next, even when the patient goes to the general practitioner, sometimes the GP also adds some time, because they say, well, you're young, or they take the same excuse and wait until they order some further investigations, or they refer to the cardiologist but not to the pulmonologist, or not order a chest CT, and then eventually they will do, but there is some time, some delay before doing that. And the GPs, they have many disorders to take care of. And of course, their primary role is in prevention, in the common health issues such as diabetes or obesity and so on. So they know COPD, they know asthma, but not ILD very well. And then the next step, when the GP is referring to a pulmonologist with or without a chest CT, is that you also have some waiting time until you see your first pulmonologist. And the pulmonologist you would see very often is not an ILD specialist, and they may hesitate. In my place, sometimes they still prescribe some steroids, for example, and see you 3 months later to see if this has changed. And of course, it has not, if it's pulmonary fibrosis, but you have lost 3 months or more. So you have many steps to lose time, unfortunately. And you also have, that's at the end of the slide on the third square, the third box, some who don't really believe in the action of antifibrotics and say, well, this might be fibrosis, but I'm not referring you because there is nothing to do. Fortunately, this is going down because people understand now that this is a field really progressing, but it used to be the case quite often. And next, the ILD centers, and here I think we are responsible. We also have sometimes difficulties or challenges to organize a center. We have an increasing waiting list or an increasing active file and not enough doctors, not enough resources to see patients rapidly enough. Or you may also have, even at this step, some administrative steps to prescribe antifibrotics, at least in some countries. And I think the barrier is, or are barriers, because you have at every steps possible ways of losing some time.
Okay, so we have heard now where the delays come from. There is a lot. There is a lot. Let's try to shift to possible solution. Elisabetta, from your perspective, what would be the most impactful changes?
Thank you, Jean-Michel. Of course, there is not only inaction we have to take in consideration, but there's a lot of action during all the pathway, all the process of the patients. And if we consider to push and to shift all the action as early as possible, of course, GPs are the most impactful change. That is our duty and our responsibility to avoid misdiagnosis and to educate and to train them in taking or thinking beyond COPD, thinking beyond asthma, thinking beyond or avoid to prescribe without exam, for example, bronchodilators, and thinking that it could be possible in the outpatient clinic of GPs to visit patients with a minimal changes which are not recognized, or like a chest X-ray. So the good strategy could be probably, to educate and to make, of course, an effort by ourselves as a clinician expert in interstitial lung disease to educate by residents, for example, a good strategy by young people to follow them and to educate that there's an increased awareness in terms of instrument that we can use, and probably to avoid what usually they use, like chest X-ray, which develop a misdiagnosis if it is normal, so guide all other clinicians to put the patient in other clinic, for example, cardiologist, or to avoid misinterpretation like inflammatory changes in chest X-ray, which means to treat with antibiotics. So the good strategy is to teach them that there are instruments that they have to use, probably in a subgroup of patients, not in every population they visit. And this is the second issue, I think. So to give them a sort of high-risk population, which means the one with smoking history, the older age, the one with possible occupational or some other exposure, the ones with family history, so the ones with some key factors which are recognized as key risk factors that could develop pulmonary fibrosis at an early stage. So it's our duty, like when we speak to a student in the School of Medicine, to teach them that there is a strategy and we have to use the right tool, which is not chest X-ray.
Thank you. And Pat, again, from your experience as a nurse, do you see other changes?
I think we need good, clear pathways. We heard yesterday from Anne-Marie Russell regarding their pathway. We in Northern Ireland are also working with a pathway, and it's actually almost complete, but due to funding, it's not been implemented yet. But I think that helps. I think also we need to maybe empower people in primary care, other nurses, allied professionals, that, if the signs are there, escalate. I think that would be very useful. And maybe I'm a bit biased here, but I think we need more ILD nurses.
Probably, I agree with you, Pat. And Vincent, if we are looking now at the system as a whole, from your point of view, what are the most important leveraging points?
So first of all, I agree. We need more ILD nurses, to be clear, because I think you play a crucial role. You're instrumental in really reducing delay, but also many other things. So I think in ILD centers, we need ILD nurses. That's definite. But it's a notion that is relatively not very much progressed, not very advanced, at least in many places. And we need together to convince the hospital directors or institution directors that we need you. For the pathway of care, I think sometimes we also need to show good examples. You've showed us a very emotional example from Claude. Fortunately, there are also good examples. And the good example is someone who begins to be short of breath or coughing. they go to their GP, who say, oh, wait, you have velcocrackles. I'm going to order a chest CT, receives the report like 10 days later and walks on the internet and say, well, I found on ILD centers, you have some kind of pulmonary fibrosis, and I'm referring directly to the ILD centers where they have a fast track. That is the good example. And you even bypass the local pulmonologist who can be involved later on for joint management of the patient. But then you have at least an early diagnosis. That's a good way. Then for the future or for what can be improved, I've listed a few points here. The first one is lung auscultation. And in my good example, you have the presence of velcocrackles. So GPs, they know how to auscultate, but sometimes they need to be a bit more educated to make the difference between what is the velcocrackles of the fibrosis and other kinds of auscultation abnormalities. And sometimes they don't dare to go further. I've heard something, but I read it down, and let's see next time. So they also need to be educated to take action when they auscultate velcocrackles. But it's a very easy tool in theory, so it's something that we need to be more active on education.
They need to auscultate.
Yes.
Not all are not doing it.
And it also applies to other kind of specialists. For example, the rheumatologist, they see many patients with rheumatoid arthritis, a few with systemic sclerosis who are population at risk for pulmonary fibrosis. The second way of improving, I think, is paying attention to interstitial lung abnormalities. So abnormalities are abnormalities we see on the chest CTs, which are not yet interstitial lung disease. So this is an abnormality, not yet a disease. And you may see that without any symptoms. And very often, the person who would see that first is a radiologist, because the patient is doing a chest CT for cardiac calcification or abdominal CT, but you see the basis of the lungs, and they spot, or screening for lung cancer, and they spot some abnormalities, and very often there is no mention of that in the report, or at least in the conclusion, and then nobody is taking action after that. So we need also some education of the medical community that these ILAs, as we call them now, they very often are the first step of pulmonary fibrosis. 10% of them progress every year. So 5 years after the observation of ILAs, about half the individuals would have progression to ILD. And the third situation is a bit more technique, a bit more complex. It's more dependent on the specialist, I think. But it's to understand that there are populations at risk of pulmonary fibrosis. I've listed some, but if you are in a family where there are several individuals with pulmonary fibrosis, or if you suffer from connective tissue disease, scleroderma, rheumatoid arthritis, for example, or if you have an occupation, a job that exposes you to asbestosis, silica, mineral dust, metal dust, wood dust, you're at risk of developing pulmonary fibrosis, and physicians should maybe be more careful in these situations at risk. So this is more for the future, but we would need to organize better the care for these individuals so that they have some closer surveillance pathway and the possibility of detecting earlier pulmonary fibrosis. This is already done for connective tissue disease in theory. It's recommended in any patient diagnosed with systemic sclerosis to have a chest CT to diagnose whether there is pulmonary fibrosis. But it's not always done, and it's something that could be in theory applicable to other situations.
Okay, thank you. Maybe Pat, back to you about awareness. What does that mean for you? Do you have some thoughts about it for patients?
Well, you know, awareness is, I suppose, put ILD on the radar.
Yeah.
We certainly need it, but there's no point in awareness if there's no action. And I think we need, you know, systems in place so that patients are picked up really early, that they get in through the system, that there's no delays. We in Northern Ireland have similar problems, delay in getting appointments, and then when we get appointments, it's maybe misdiagnosis or, again, wrong treatments for a while. So, along that pathway, there has been that delay. So awareness, but awareness with action.
Okay, thank you, Pat. And Elisabetta and Vincent, maybe to close this part about early diagnosis, what about research? Are you aware of any projects to facilitate early diagnosis?
Thank you. I think that I don't know if we will have an overlap regarding research project, but I think that an emerging area and very interesting area is regarding, of course, the gold standard for diagnosis, which is HRCT. HRCT could be a good example to give us the accurate diagnosis, but depend on the radiology expertise, it depends on the center. So a good example of research project are regarding the use of, for example, software program of AI and machine learning that help the radiologist, not substitute, but help the radiologist to detect very early which are the minimal changes like interstitial abnormalities, and interpret very well the typical pattern as compared to the not typical pattern. So it's a kind of mixture of help each other by a software that, as we know, help also clinical trial to interpret. So it's a kind of help in speed up the diagnosis, but also probably in the future, I hope, to give us some key findings or some characteristics that could predict who progress or who are not a progress disease. This is a kind of probably ambitious program, but could be, yes, of course, a useful way to think about a good strategy with a useful tool, which is not an invasive tool, and help all the clinician, even the not expert clinician and even not the expert radiologist. The second point, I think, that was mentioned by Luca Richel this afternoon is regarding surveillance program. And also, Vincent, you stressed the concept of familial pulmonary fibrosis. And I think that the other strategy, the other research program that we have to invest is regarding the detection of relatives of patients who are affected, but not only the idiopathic sporadic forms, but all the interstitial lung forms, also the connective tissue associated forms. So it's a kind of huge program that, of course, need investment, of course, need funding, but we have to look at the fact that probably the awareness now is very low regarding familial pulmonary fibrosis. And this is if we look at the other way around, the awareness is low because we are not thinking too much about this problem, probably because we are not used to think about all the relatives around the patient who is affected.
Thank you. Vincent, do you see any?
I absolutely agree. We didn't exchange on that, but I have the two same issues, so I won't repeat, but just maybe as a follow-up for the familial pulmonary fibrosis, one difficulty we have is very often when the patient comes for diagnosis to the ILD center, we don't know yet it's a familial disease. And now we ask the question, is there anybody else in your family who has suffered from pulmonary fibrosis? And if so, they would know the word. We also ask about some symptoms or signs which can be associated, such as very early hair graying or history of hematological abnormalities or liver abnormalities in the individuals or in the family. But even when we do that, very often we don't detect that it could be a genetic disease. And a couple of years later, you have a relative like the brother or anybody, a close relative who comes and it becomes a familial pulmonary fibrosis. So what I mean is that the difference between familial and sporadic is not so easy. And actually, there has been a couple of studies showing that if you take patients who have sporadic IPF and you do a study in their brothers and sisters or nephews, you will find some interstitial lung abnormalities and sometimes ILD. So maybe one day we'll go further and we'll also propose some detection or screening in the relatives of idiopathic pulmonary fibrosis, because it seems to be quite frequent. And about artificial intelligence, I absolutely agree. I think that's the main research area for diagnosing, and especially diagnosing early, for making a better diagnosing, for trying to predict prognosis, for trying maybe one day to predict some response to treatment or who will benefit the most from what or whatever treatment, and possibly also for interpretation of the ILDs, of the very early abnormalities, because it's not so easy also today to say, well, this abnormality will not progress and that one will progress to IPF. We need to take action.
So I understand that we have opportunities and room for improvement in early diagnosis. So my next question in that case will be, can we also do more for prevention? And what does that mean exactly? Sometimes the feeling that we are being a bit too shy about prevention. So Elisabetta, to start, maybe what are the known risk factors and which should be more visible in public and professional awareness about prevention?
Yeah, this is a very important question, and also is related to the previous concept of educating and increase awareness. We have to educate regarding known risk factors, at least what we usually see in our patients. For example, aging, we know that pulmonary fibrosis occurs in over 60s, but sometimes aging is a kind of, or took place like a misinterpretation of other diseases, or like deconditioning, or other COPD or other obstructive diseases. So it's a kind of a mixture of risk factors that could not really be clear for GPs. And of course, another great deal we have with the implementation of all risk factors regarding occupational lung disease, which is a great job that we have to start to think about in collaboration with occupational health professionals, which is not something that we are used to do. In our clinic, we are used to communicate with rheumatologists, with radiologists, with surgeons, but with occupational lung professional is a kind of moving forward and try to be connected with them, because they are stick to do the classical exposure, which is asbestos, which is silica, which is a lot of different metal dust. But as we know, from our perspective as pulmonologists, we are seeing a lot of occupational exposure, for example, not well categorized by the classical occupational lung disease. For example, I give you some example for my clinic, dental workers that develop pulmonary fibrosis because they don't use DPI, or some other occupational which took place like hobbies, like environmental, like domestic exposure. So there's a lot of job that we have to develop with ourselves to clarify which are the main risk factors, and to transfer to send this clear message to the population, and also to GPs, and also to general pulmonologists, also to underline which are the at-risk population. And of course, again, family history and smoking history are the main risk factors among this population.
I was focusing about risk factors, Elisabetta, but maybe prevention is also earlier detection and maybe preventing progression. Do you have any clues about it?
Yeah, when we talk about prevention, I think that we have to reflect regarding not a unique pathway, not a unique action. We have to reflect regarding different step-by-step process, and of course, hopefully, primary prevention would be for ourselves to avoid the development of lung disease, and this optimistically is not doable right now, but we can think about avoid the known risk factors. So again, to develop programs to avoid smoking history among people, avoid second-hand smoking history. We have to remember that is also a well-known risk factors. To teach our professional, of course, regarding exposure, and this is the link with the occupational lung disease, professionals. And again, of course, this is the primary prevention that could be an action before the development of pulmonary fibrosis. But our duty, our main task, of course, is regarding secondary prevention, which measures, of course, identifying subclinical disease by HRCT. So again, try to develop a strategy to implement the use of radiological tools, the right radiological tools, but at the right moment in the right patients. So again, a mixture of at-risk population that should be investigated with the right tool, with HRCT, probably with the help of AI, that help us to detect the very minimal change at the early stage. And then the great job that we have to do in our, at a national or probably at a regional level is, regarding secondary prevention, is to structure what is very well described yesterday by Anne-Marie Russell, a very strategy or standardized protocol to develop step-by-step who is at risk from GPs, and then to push them with a fast track to the ILD centers in a standardized protocol, in a standardized program, which is not a common program that could be usable in every country with a similar pathway. We have to think about strategy that could be at a local level, at a regional level, that are in conjunction and in communication with our health system, our regional health system. So there's not a unique strategy, but different strategy, country by country. So everyone's responsibility should be to find the solution at our local level. Of course, tertiary prevention is what we are doing now. So using therapy at early stage as possible, not avoid the approach wait and see. So again, teach to general pulmonologists not to wait and to treat patients at the early stage, and to use our multidisciplinary discussion, again with a regional network, so facilitated the patient not to move from a center to another, but with our telemedicine tools, facilitate the documentation that come to the ILD center instead of pushing the patient away from the local center, and again, preventing comorbidities and complication.
Thank you, Elisabetta. Vincent, again, about innovations, you like it? Do you see any innovation in prevention in the coming years?
Yeah, maybe stay a second on this slide, please. Because I very much like what you explained on primary prevention, trying not to get the disease, secondary, which is acting early, and third, or tertiary prevention, which is trying to slow it down, but it's already late. And we have to understand that right now we are more on the right side. So the innovation would hopefully be at least for the secondary prevention and trying to be as early as possible. And that's why I think this is important to understand each other. And the primary, maybe it's on a different level. It's not really medical. It's more political and decision-wise.
So about innovations.
Yeah, so about the innovations. So of course, I don't know the future, but no. But what we know is that there is some research going on, and then we can expect some progress. And we can expect some progress in biomarkers. And there is a very high unmet need in biomarkers. There are several candidate biomarkers which have been described with pulmonary fibrosis. But so far, they are not demonstrated to be extremely useful because they increase when they have when there is pulmonary fibrosis. Sometimes they increase when the disease is getting worse, but they don't really predict. So as compared to pulmonary function and chest CT that we know how to interpret already quite well, their added value is relatively small, or at least from what has been demonstrated. So we need better studies on biomarkers and also new biomarkers that hopefully might help us making easier diagnosis, maybe less invasive diagnosis, and earlier diagnosis. Less invasive, we haven't discussed much, but when we get the chance to see a patient with very early disease, it's even more difficult to diagnose because the chest CT is less typical. And then if we want to make sure this is IPF, for example, we would have to do a biopsy, which is invasive for the patient. And sometimes if they don't feel much symptoms, they would not accept and say, well, I don't feel sick, so why should I do an invasive biopsy? Next, there is a lot of research on the treatment of pulmonary fibrosis. So this is outside of field of early treatment, but we can probably improve the treatment of early pulmonary fibrosis. Today, why we don't treat early pulmonary fibrosis is first because we don't diagnose very early, but also because when someone has early form of pulmonary fibrosis, it's difficult to treat because the treatments are not perfectly tolerated, and they don't improve, they slow down disease progression. So many patients would say, well, I'm not so sure I'm ready to start treatment, I prefer to wait. And then we eventually initiate treatment as late as everybody else. So with progress in the drugs available, we may have drugs which are more effective, hopefully in the future, and can be used earlier because they are easy to use and better tolerated. So it goes into this direction of earlier treatment. And then we also need the evidence. That is, scientifically, we need to make sure that if we want to treat valvular fibrosis, it's effective. And so we need also to have studies on fibrosis which is not yet typical IPF, which is not yet progressive pulmonary fibrosis, but maybe tomorrow it will be. But today we don't have the evidence to demonstrate that treating that fibrosis, which is not yet progressive, is helpful. And we need studies for that. And we also need studies even before. How do we treat interstitial lung abnormalities and prevent them from progressing to interstitial lung disease? That we don't know yet. And of course, these are abnormalities. So by definition, individuals don't have symptoms, they don't have a disease, they are not patients, and we cannot offer something which is a drug, which is high cost, and with some tolerability issues. We need something that can be used very largely, broadly, easily, and with excellent tolerabilities. And today we don't have that treatment for interstitial lung abnormalities, like when we see that someone has high tension, hypertension, or high cholesterol, we treat to prevent the outcome, which is cardiovascular event, cardiac myocardial infarction, or cerebral ischemia. And we treat the abnormalities to prevent the disease. It's the same for interstitial lung abnormalities. We would need to treat abnormalities to prevent the ILD, the IPF. We need some research from that. So it's probably further down the line. And I think the tertiary to reduce risk of progression, I think Elisabetta has covered very well already. This is fighting against all the risk factors, which for the majority are risk factors for developing the disease, but also for the disease to progress. So these are the same actions. And with addition maybe to infections, and I think the nurse, the ILD nurse, has a very educational role here to tell them, well, you should try not to get the flu. So get vaccinated, wear a mask when needed, and so on. Wash hands, of course, to try and reduce the burden of viral infection. And of course, any respiratory exposure is bad as well.
Any other recommendation for patients to prevent risk of progression? No?
Well, these are listed on the right, and we've covered a few already. Yeah. Antifibrotic treatment is of course the main measure we can do, but also any kind of insult to the lung is suspected to increase the progression of the disease and possibly to trigger acute exacerbations of pulmonary fibrosis. And we now know in this room that the acute exacerbations are not like acute exacerbations of asthma or COPD, they're much more severe. That's really an acceleration of the fibrosis, and we need to prevent whatever can trigger these acute exacerbations. And the suspects or the culprits are the viral infections, very often, the peaks of air pollution, and sometimes comorbidities like reflux. So these sound like very general measures, but these, in the end, they're very important because the totality of them will help reducing the risk of triggering acute exacerbations.
The combination, in fact, of all this. From a clinical perspective now, maybe Vincent, because prevention is a beautiful word, but who is responsible for prevention? So if we look at professionals from a clinician perspective, is there one thing you think professionals are not doing well at the moment, and when it comes to
If you look at the list on the right, you have some which are the job of the GP, for example, or sometimes ILD nurse. In my department, the ILD nurse is helping me taking care of the calendar, not missing some flu shots or things like that. They do that better than the doctors very often. So that's one job. Then the pulmonologist, we have the role of ensuring that the patient is treated for reducing the progression of the disease. And this figure is on a more general level, where you have on the left, if you can click, please, you have patients or populations at risk. We've seen that with Elisabetta, and we need to identify the exposures. That's on the top. So some would have some organic exposures, some would have some dust exposures, and so on. And then depending on what type of exposure, the role of the professionals would be different. For example, the pulmonologist would insist a lot on smoking cessation, the GP as well, but the occupational doctor would possibly orientate the patient to a different job position, for example. In my NDD, the occupational specialist participates, and obviously we don't know their job. They know a lot more, so they would help preventing that. And on the right, you have things that are more on the political level. That is, we have to understand that a lot of the risk of developing pulmonary fibrosis and of progression of the pulmonary fibrosis is related to tobacco smoking, air pollution, and occupational exposures. So we need to have some actions to fight against tobacco smoking, air pollution, and occupational exposures.
Okay, thank you, Elisabetta. Elisabetta, something to...
Yeah, if I can
some thoughts?
Provocative, I think that is everyone's responsibility to take action regarding prevention. So it's not a kind of GP's duty or pulmonologist, general pulmonologist, but we are in charge because we take care of pulmonary fibrosis. So we are the person in charge and the person with the main responsibility to teach from the beginning also citizens. For example, with vaccination program, for example, with avoidance when there is the air pollution, the peak of air pollution. So it's a matter of being responsible of all the process, and of course, who is responsible? The people that take care about pulmonary fibrosis. So we are in charge to take care of all these kind of steps. Of course, with human resources, it could be possible, for example, teaching young students, teaching residents, so a sort of using them to spread this kind of knowledge in our territory. This is my view.
Thank you. And Pat, about patients again, do you have some view? What could help the patients to act earlier, because these are beautiful guidelines, but in the practical life, do you have...
That can be very difficult. And as I alluded to earlier, in real life, patients often normalize symptoms and they really do adapt. Yeah. So, and they can do this for quite some time. And sometimes what prompts action is usually a trigger. And the trigger usually comes from family members or, you know, a carer. And then some of the patients might, you know, seek help and try and get into primary care. And there lies the problem of maybe, you know, getting in there. So there's, there's lots of problems. But I think it is difficult when you have people who, normalise those symptoms. And I think a symptom that we don't really talk about until the end is fatigue. And I think a lot of times until they're really hit by fatigue, that's maybe when they'll act that wee bit earlier.
Mm-hmm. Thank you. Just before closing our discussion and open the discussion with the audience, a last question for each of you, but a quick answer, please. I will ask you to choose a top priority, one priority action that should be requested to the authorities to improve prevention. Start. Who want to start?
The first priority is to think about our regional, local rules with the health system and standardize protocols which develop a fast track for at-risk population. This is my view.
Thank you, Elisabetta. Vincent?
I would go on the political way. So we have to understand the notion of attributable risk. So in a given person, you cannot say, well, this is due to smoking, this is due to air pollution. But on a global population, you can calculate the risk of pulmonary fibrosis, which is due to genetics, about 30%, which is due to tobacco smoking, about 20%, which is due to air pollution and other kind of exposures, about 20%, and then the rest. Meaning that if you remove tobacco smoking and air pollution and job exposures, you remove 40% of the risk of pulmonary fibrosis. And in addition, these risks are shared with other conditions. You would also reduce the risk of lung cancer and et cetera, et cetera. So my top priority would be that asking the authorities to implement measures so that we reduce air pollution. And if we pick one, like the low level of air pollution exposures in large cities, I think it's very important for Europe to implement.
Good point. And Pat, on your just one.
Okay. Early access to diagnostics, pulmonary function testing and HRCTs to try and get patients a lot earlier in the system.
Thank you a lot for your views about early diagnosis and prevention. I will now open the session question to the audience. Audience online. Do we have question online?
We have one, and I would also like to show the poll results you in the beginning.
Yeah, for sure. Yeah, I'm not surprised personally, but it means that more than half we are diagnosed more than 2 years after the first symptoms. So,
It's still true.
It's still too much. Yeah.
So we have one online question that yesterday in the US, the PREEMT pulmonary fibrosis launching to study early diagnosis and treatment. And the question is, what a European parallel to PREEMT PF look like, and where does the patient and caregiver voice enter that pipeline, at recruitment or earlier, in defining what early actually means?
Personally, not sure to understand the question. Vincent, Elisabetta?
Is that in clinical trials?
I don't know.
The involvement of patients.
This question is not clear for us. Could you?
Yeah.
Yesterday, Scott Stazak announced NHA PREEMT PF is launching in the US to study early diagnosis and treatment. And Jean-Michel raised the same question from the floor. The third problem, early treatment requires early signals, and the qualitative signals, for instance, the patient who stopped walking, the caregiver who noticed, proceed the diagnostic code by months or years. Question for this panel, what would the European parallel to PREEMT pulmonary fibrosis look like, and where does the patient and caregiver voice enter that pipeline, at recruitment or earlier, in defining what early actually means?
If I understood the question, probably there's two actions. I don't understand if the patient voice or patient recruitment would be an action in the pipeline of drug development, like, of course, patient perspective in the design of the study protocol, or if it is the patient voice and patient perspective in action to prevent and to do early diagnosis. Probably is the second one, not the pipeline of drug development, but is an action to help patients, that help parliament or help politician or help clinician to give an early diagnosis or to give the right action. I think that we are not right now in the position to say that we have this kind of role for patients so easy, or I don't know if in other country, but I don't think that in Italy we have this kind of perspective from patients. Of course, we have EPAG from patients that help us to speed up certification, a lot of other issues that are regarding early diagnosis, but probably the issues is regarding the patient voices in the standardized protocols that we are right now have to design with our Ministry of Health. I think, I don't know if...
Yeah, I think the patient also have a voice in the design of the clinical trials. So of course they're not special, well, some of them can be, but in general they're not specialists of the statistics and the methodology. But it's good to have a view of the patient on the design. And for example, in some recent trials, the patient groups advocates also had some advice about reducing the number of visits or avoiding some unnecessary tests. So I think that's very helpful for going together to the direction of good trials.
And this is something we are already practicing in some countries, and also with the federation, with the PFF Federation. We are more and more involved at the early stages of research and to discuss about protocols and and 6. Any question in the room? Yeah.
Hi, I have a question for Dr. Balestro. I attended a convention 1.5 years ago in Padua because you are one of the referral center in Italy. And I remember that you were going to launch a campaign for general practitioners for better understanding the first symptoms like the velcrum crackles, etc. And also you were stressing the importance of physiotherapy. So I was wondering if you are still on with that initiative, and if so, if you found it cost effective, if it is a burden in terms of budget, or if in the end it is, as I said, cost effective, because letting the general practitioners better understand that can mean early diagnosis or early referral to ILD centers. So perhaps that is even a money saving.
Yeah, thank you very much. This is a great question. Thank you. Yes, I remember this kind of initiative we developed together with the Federation, and thanks to the Federation, during the month dedicated to disease awareness, which is September. So with the help of the Federation, with the help of our Patients Association, Stefano Pavanello is here, we develop this kind of initiative which are focused that year to general practitioner. Then we change another year, we were focused mainly with general pulmonologists, which are really a good other strategy in our view, in our regional context, because they are probably another barriers for early diagnosis. So we take the advantage to take advantage of the awareness month of September to speed up this kind of initiative that year by year are changing. Of course, general practitioner was an experience that we had and was time consuming to develop their interest, and this is why we are talking about early diagnosis with GPs, because they are usually mainly focused with a great disease, with a great burden, which is not pulmonary fibrosis. So to invest with them is costly and need human resources, and need also, for example, youngers that probably attend GP's clinic instead of taking GPs outside their clinic. This could be the other strategy that we would like to develop in the near future.
Thank you, Elisabetta. We have then a question from Lisa, I think.
Yes, hello. My apologies that this is a policy question. I was glad to hear silica dust mentioned. It's very topical in the UK just now because there's a bill on its second reading in Parliament that is the silica dust exposure bill that would look to ban dry cutting and have mandatory health screening. So I just wondered whether there's anything similar in the pipeline across European countries, and if not, are there any patient-led charities or patient support charities that are looking to have something like that put in place for prevention?
So exposure, this is a difficult question. Exposure to silica
But short answer.
is a risk factor for pulmonary fibrosis, but it's also a risk factor for other diseases. And so it's identified. I'm not aware of big campaigns for that, but the occupational specialists are well aware, and at least in France, you have some coverage possible. But it has become a rare cause of official silica-induced pulmonary fibrosis just because there is less exposure to silica in general. And I'll stop there.
Thank you, Sorry. We have two remaining questions, one from John and then Eleni. John, please.
Yes, pulmonary fibrosis take years to develop, often decades, right? And sometimes I wonder, today's exposure climate, we may not see the results of until our 14th EU PFF summit in 24 years. I'm thinking about microplastics. May that have an impact in the future? And also today's youth vaping, will that be the same risk factor as cigarette smoking? But especially that with microplastics, because that can enter your body, not just through your lungs, but several other ways of getting in. Is that a sensible risk factor?
I take all the difficult questions, saying I don't know. You know, the epidemiology of tobacco smoking started like early 20th century, and we learned that it is a risk factor for pulmonary fibrosis like at the end of the 20th century, and we had better studies beginning this century. Air pollution is even more recent, that we know that it's a risk factor for pulmonary fibrosis and for acute exacerbations. I think your question is good, but vaping or exposure to microplastics, maybe we'll know in 20 years whether it's a risk factor. I have no clue right now. Nanomolecules as well are possible candidates for toxicity in the lung.
That's for sure something to follow up in the future. Eleni, you have the last question. I know you. Yes. Short question.
Short? Okay. What I have to say is that in all national healthcare system, there are prevention care about a lot of diseases, about cardiological diseases, about cancer. Why we don't think to have prevention tests for pulmonary diseases, not with CT scan, but with some way to check our lungs and to prevent the health of our lungs. I stop.
Difficult question again. I think that there is not a right answer. As I said before, we should think country by country. So preventive action is not a unique action in all the country. Everyone has some rules. Everyone has, for example, regional health systems. So we know our barriers, we know our limitation, and some common action could be developed everywhere, but some other are specific of each health system. For example, my system is different from Vincent's system, and I know my limitation, and probably I act with different measures which are dedicated for general pulmonologists. For Vincent, could be preventive measure mainly with GPs. So I think that the strategy could be developed at the local level and not a common strategy for everyone.
And you mentioned not the CT, but for example, spirometry, we know it's not enough to detect pulmonary fibrosis. Many patients initially would have a normal spirometry, not the LCO, but spirometry, which is a relatively easy test, would not be sufficient for screening. It's good enough for COPD, but for pulmonary fibrosis, it's probably not the right tool.
Thank you.
Sorry for the remaining question, but we need to conclude. I am under pressure with the logistics, so we need to conclude. So thank you to our speakers and panelists for the open discussion, and most important for me, for call to action. I would like to be back at the end with Claude. We all know, most of you know some Claude. It could be a partner, it could be a parent, a friend, a patient. So we have seen yesterday morning also that there is a great pipeline of new drugs coming. So for me, as a conclusion, let me share a dream. I don't know when, but we will have early diagnosis, early treatment. And my dream is that sorry. PF is becoming a chronic disease, as many of chronic disease, where we can live with it, with a treatment, because early diagnosed, we can live with it 10 years, 20 years, 30 years. So let us all together transform this dream to reality. And thank you for your attention.
Thank you very much.